in theatre here, as you can, I think you can just have a look now, yeah. Steve is our patient who is having an operation on his ankle. At the moment, as you can see, the team are just preparing, I think that's an iodine solution, isn't it? Yeah. Yeah, an iodine solution which makes the whole part of the ankle clean. Now, it's a common sporting injury that happens to most people, of course, it's a sprained ankle. But for Steve, it was happening all too often. About 15 minutes ago, I asked him when it first happened.
About 10 years ago, in Spain, walking down an irrigation channel, and I just gave way on the side of the channel.
And I gather it's happened quite a few times since then?
Yeah, about 5 times.
So what brought you first? What made this all happen, get to today? What got you to this point?
From running in the park last summer, and my ankle just gave way completely. It didn't sprain, it just gave way. And it started clicking, really, whenever I walked.
So what things can't you do now?
I can't run for a bus. I can't walk long distances, but it's pain. It gets more painful if I walk long distances. If I walk more than 2 or 3 miles, it starts to ache quite a lot. OK. Mr Sam Singh, good morning.
Good morning.
You're going to be conducting the operation. What exactly is the problem?
Well, it's a very interesting problem here. You can see this gentleman, he's had recurrent injuries to the outer aspect of his ankle. Now, obviously, he's damaged his ligament which runs there. But in addition to this, there's a very important tendon called your peroneal tendons. These run behind the bone here, which is called the fibula, and they help stabilise the ankle as well. Now, what's happened is at some stage this has been damaged, but certainly in July, he recalls that his tendon started jumping out of the socket.
And when you say jumping out of the socket, I mean, is it quite...
It's quite painful and it's quite uncomfortable, and he's lost all confidence now in running. Now, it's a relatively rare condition. Ankle injuries are very common, but this is a relatively rare condition. It's a kind of the extreme form of ankle injury. So if you can just show us, you'll see here, this is the normal tendon. If you move your ankle for us, sir, you can see there's tendon there. You can feel it there. Tendon's popping out of joint.
Right.
So it jumps out and it pops back.
And right now, Mr Singh is just in the process of getting Steve ready for the operation. If I just have a quick word with your good self, Joseph.
Yes.
You did something quite different for Steve, didn't you? Something called nerve blocking, I understand.
We have, yes.
So what exactly is that?
Well, we have anaesthetised the nerves that supply the leg. Basically, there's 2 major nerves, the femoral nerve and the sciatic nerve, which run along the groin. And I place local anaesthetic. I use a bit of specialised kit which generates electrical activity. So I place a needle close to the nerve and turn the electrical currents gently up and cause the nerves to get excited and then contract the muscles.
And why do you do that in particular?
I need to be very precise in the placement of my needle to be very adjacent to the nerve. Then I inject local anaesthetic very close to the nerve. The nerves will then be anaesthetised, and this will give adequate pain relief, which will last anything up to 24 hours, which is very important because this surgery can be quite painful.
Right.
And so if you are able to provide excellent pain relief for the first 24 hours, it would make a huge change. And it's very beneficial to the patient.
Right, well, thank you very much. I'll let you carry on. I know you've got stuff to do.
Good.
And hopefully we will be back later. Thanks, Nadia. I'm doing the marching on the spot thing, which is apparently what you should do if you're a little bit squeamish and you're going to see something squeamish, and I've seen something squeamish. Steve, who's being operated on, has sprained his ankle 5 times in the last 7 years. Mr Singh, this morning, is hoping to, well, repair the tendon that keeps popping out of where it should be. Mr Singh, is this a good point to talk to you?
Yeah, I think we've got to the stage we've exposed the tendon. So what we can show you is that the tendon is just like...
Well, just bear with me one sec. If you're squeamish, you might just want to listen for a sec as we show you the tendon. There's no blood. It's very clean, but you might just be a bit squeamish, so you might want to march on the spot in your living room. Off you go, Mr Singh.
OK, so these are the tendons. The 2 tendons, peroneus brevis and peroneus longus. One of them is flat, and what we've found is that these are the tendons. Now, normally, they sit behind in the groove there in most people. What's happened here, his tendons are jumping forward and sitting there. So we're going to reinforce the tissue so that it stops happening, and on top of that we're also going to make the groove in the bone deeper. So we're going to basically cave out a part of the bone, push it in so that this groove, so the tendon stops jumping.
Now, I see you're using those are like red rubber bands, aren't they?
This is like a rubber band. It's called a vascular sling, and it's just nice for us to show things and for keeping the tendon safe. It's marked in red. We want we know we need to watch out for it, for danger.
Yeah,
so
and
we don't damage the tendon.
You've got a sterile pen there and a piece of paper because you were going to show us.
I can show you, no problems. Now, so if we look at the ankle from this way, so side-on cut that way, this bone is called the fibula, and it's roughly this shape, okay? And this is one of the other bones. So these are your two bones in your ankle.
Yeah.
Now, the tendons sit there. What's happened in this gentleman is the ligament that normally stays there has torn. As a result, his tendon now goes and sits here, and the ligament is all stretched out, okay? That's called your retinaculum. That holds it back. So what we're going to do today is we're going to take the ligament there, repair it, reattach it here, and on top of that, we're going to take out that much of the bone and bury it inside so that these tendons now have a nice groove in which they can sit.
Now, so is there much cutting, apart from getting in where you have, is there much cutting involved?
No, this is the exposure. It's not a very long exposure, but I can see what I need to see. Unfortunately, I have picked up another problem during the surgery, and that he's actually got a tear in his tendon.
Right.
This is quite common because you can imagine if this tendon keeps jumping out over the bone, it ends up fraying the bone. And that's what's happened here. So we're going to repair the fraying, and then we're going to approach the rest of the case.
Are you happy for us to stay here?
Yeah.
Excellent.
Please do.
Please, you know, obviously you'll be carrying on. So the sterile pen, by the way, that pen is sterile. Everything in here is sterile. In fact, Grant, go back a bit. You can see we're working underneath this big shield, which keeps the pressure, the air pressure, the same all the way around. Right? If you can stop marching now. Thank you. Thanks, Nadia. The noise you can hear is a very small saw that Sam Singh, Mr. Sam Singh, is using on Steve's ankle. Steve, who has, well, had sprained ankles for the last 7 years. So you sound like you're stopping there, Mr. Singh.
Yeah, I've just about finished the cut. So I'm making the bony trough, which I'm now going to push in and make the groove, therefore, deeper. So we've just finished making the trough. Now we're going to use something called a very simple instrument called a bone tamp, which is just used for pushing bone. And we just do it very gently, we just push that in.
And so at the moment you're pushing the...
Just pushing that little window I made, just pushing that in gently into the bone. And the nice thing is it's still covered by all the periosteum, which is a good source of healing, and it gives a soft thing. So if I just took the bone away, then it would be very rough, and then it could cause further damage to the tendon. So what we're doing at the moment is just pushing this in. Now, it's very slowly because obviously we've cut the bone and we can cause a fracture, so we have to be very gentle here. Just slowly work our way in.
Is it a very common injury? A very common...
No, I mean, this is an extreme. I mean, there's probably... It's actually a rare injury, but it's it's really very disabling. What you'll find, Andy, is that generally ankle problems get neglected. And if you look at someone with a knee problem, we all know our knee gives way or it jams on us. We need to see a doctor. But people, I find more and more that my patients are coming to me at really quite long intervals. They'll often have been to A&E, they'll have seen a doctor there who will have turned around and said, well, you haven't got a fracture, therefore go home. But often these ligament injuries are much more disabling than actually having a fracture. I know most fractures unite in 6 weeks.
Yes.
You know, with Wayne Rooney's foot.
Yes,
most fractures should heal, we hope, by 6 weeks.
Well, we've all got our fingers crossed for that, let's be honest.
Certainly have, I know.
So, in the case of, Steve and his ankle, he'd been wearing an ankle brace.
That won't help. It often does help. But in this particular case, it doesn't. And the reason simply is because his is an anatomical problem. Now, normally physio helps, braces help, and certainly I very rarely operate on an ankle without knowing that I've had physiotherapy or bracing. But here, there's nothing that what this guy really needs is just to be reconstructed.
So are you now towards the final stages?
Yeah, we are towards the final stages.
So what will we see when we...
What you'll see now is you'll see that the tendon is back in the groove. I've managed to push that bone in and very nicely deepen the groove. Can you see that, Neerav? Yeah, you've not seen this before either, yeah. OK, so if we pop back in a couple of minutes, you'll be able to... Yeah, certainly. Simon, well, thank you very much for now, Mr. Singh. Thanks, Ainsley. Now, Mr. Singh, may I ask, what stage are you at now? Yeah, we've done the bony groove. Now we're just repairing the soft tissue that had been pulled off, and we're putting it back so that we can bury the tendon nice and deep within the groove.
And then you'll stitch the outside?
Stitch the outside, yep, and then we'll close up the wound and then put a plaster on.
Bit of plaster? OK, well, thank you for that for the meantime. Now, breast cancer is very rare in men, but 81-year-old Roger has recently been diagnosed with the disease, and now he's on his way to theatre for a mastectomy. Dr. Sam there got a bit of a ripple in here, didn't he?
Yeah, yeah.
You obviously all know Dr. Sam.
We do.
You do?
He's a hard-working SHO of ours.
So, well,
yeah, well, we near the end. We're just about to finish.
We're
We're just putting our last clips in, but basically the operation is done. If I go to show, you can see before, as we moved his ankle, the tendon would jump out.
Yep.
Now, as we move the ankle, the tendon is absolutely fine, and it's nicely locked in place. Now, it's a soft tissue repair.
You use staples, sorry.
We use staples, yeah. It's the same as using sutures, and you get
Okay.
exactly the same healing.
Right, OK, so do carry on.
And they're easy to take out. Now, the only thing is we need to put him in a plaster because it's a soft tissue operation. I repaired the structure, so I want it all to heal up. It's not obviously strong enough for him to start running on yet, so we're going to put him in a plaster for 5 to 6 weeks, and that's what we're going to put on now.
So even when you don't have broken bones, you sometimes use plaster?
Yes, yes. I mean, plaster is very good for getting wounds to heal. We just call splinting them, really, and that's what we're doing at the moment. So we're just going to dress the wound, and then it's like a temporary plaster. It's not. It allows for swelling. It's like a taco shell, so it's fill on the outside, but if you fill it up, or the ankle swells, the plaster opens up. But it gives them a bit of support, and that's what they need in this early stage.
So you said he'll be in plaster for around 5 to 6 weeks?
He'll be in plaster for about 5 to 6 weeks.
Is it the kind of procedure where it will be fine, you know now it will be fine?
I know it'll be fine, and I won't touch it. I'll leave this for 2 weeks. When I see him, we take the plaster off, we put a new lightweight plaster on, and then we take it off for 6 weeks. He's going to be fine.
And I gather you've got a bit of a dodgy foot yourself, haven't you?
Oh, yeah, I have, yeah. I had a lot of foot pain, which is one of the reasons I started doing foot and ankle, actually.
Really?
Yeah, because it's kind of a bit of a neglected area.
And I know that your father's an anaesthetist himself.
Yes, he is.
So you've gone further than your father.
Well, it depends. What do you think, Joseph?
It can be argued either way.
It could be argued either way. OK,
Some would say I've gone back to caveman era, but
yeah, exactly.
I'm certainly using a lot of hammer and chisels. But
have you had your own feet looked at? Because, of course, you can't even look at your own
I can't
feet.
even look at my feet, but I don't know. There's no one else I trust with my own feet.
Really, than yourself. Exactly. So, and also, you are the youngest orthopaedic surgeon.
Yeah, in London, yeah.
In London?
Yeah, I was appointed at the age of 34.
And that's what, 16 years training?
Gosh, a long time, yeah, 16 years, I think, yeah. If you add all medical school and everything, yeah, 16
Right.
years.
OK, will we get to see the first bit of plaster going?
Yeah, we will do, certainly, yeah. So Neerav just dipping the plaster now. We got the...
Oh, we're running out of time, I'm afraid, but don't worry.
OK.
But thank you so much for letting us
No
spend
worries.
the morning with you.
That's excellent, and nice. Thanks, I could be of some help.
Thank you very much indeed. Nadia, fascinating stuff once again.